Hello friends, greetings from Dharamshila Narayana Super Speciality Hospital. I am Dr. Kanika Sharma from Radiation Oncology Department, and today I have with me the esteemed consultants from the BMT and the Hemato-Oncology Department, Dr. Sarita and Dr. Suparno. Please briefly introduce yourself to our audience.
Hi friends, I am Dr. Sarita Jaiswal. I am a consultant in the Department of BMT and Hematology.
I'm Suparno Chakrabarti, same in the Department of BMT and Hematology. We run a department which comprises of not only bone marrow transplantation, but we do sort of niche transplants in terms of doing haploidentical transplants in particular, and we cover all aspects of hematology except coagulation, both malignant and non-malignant.
So as we know, like hemato-oncology, it's one of those fields people don't know much about. People are not aware of what all diseases you all treat. I mean, I think with bone marrow transplant, everybody associates with it, that it is something for the cancer. So a lot of people talk of thalassemia also, but today we want to talk about sickle cell anemia. So can you share, Dr. Sarita, what exactly is this sickle cell anemia?
Yeah, Dr. Kanika, you said rightly that people are talking about thalassemia, but we hardly ever heard about sickle cell anemia. So sickle cell anemia is also one of genetic disorder of hemoglobin. So what happens here? So our blood contains red blood cell, white blood cell and a platelet. The shape of red blood cell is normally a donut-like without a central hole. But when this cell changes to sickle shaped, it turns out to be sickle cell anemia. The sickle cell anemia, what happened is sickle shaped RBC, they become sticky and stiff, and so they cannot traverse easily through the small capillaries, and that leads possibly to the problem. At the same time, there is hemolysis and the vascular blockage. Symptom patients present with these problems associated with hemolysis or vascular blockage.
So basically that abnormal shape is causing so many functional problems.
Yeah.
So sir, is it very common in India, or is it something more in the West?
I mean, this is something that I have been struggling to bring to the attention of the lawmakers for the last 10 years. If you look at this distribution, where the darkest color is the maximum density of sickle cell anemia, you'll find that apart from some area of Western, Eastern and Central Africa, the next most populated color is India. Then the question is, why don't we hear about it so much?
So why isn't it talked about? I mean, I'm surprised myself to look at this world map showing that we are such densely having the sickle cell anemia.
We are the second largest population of sickle cell anemia or sickle cell disease. The answer lies here, that this is a disease of the tribal population. So if you look at it's possibly the most ancient inherited disease, and if you look at the genetics of it, so it's distributed across the world. But as it might be interesting to mention over here that the first people in the face of the earth were in Africa. So the African people were the first people on the face of the earth. Now they migrated to different parts, including Europe and India and the other Asian countries. And in the course of that, they acquired newer mutations. They lost some and they acquired some. Now sickle is one of the earliest mutations, and it is a single amino acid substitution which takes place. So it's a monogenic and a very simple mutation. And it is, that's the other thing, that the maximum number of people in the world who suffer from sickle cell anemia live in India or in Africa. And that in India also it's clustered around the Chota Nagpur belt, that's a coal mining belt.
Right.
And that is probably the reason, because it does not affect the rich and the powerful.
Metropolitans. Right.
that you don't hear about it so much, and there is no investment, no talk about it, no planning, no policy. So it's largely an unknown disease where we have a huge population at a given time, more than 1 lakh people affected with this disease.
So, ma'am, if it happens, so do the symptoms come in the childhood itself? How would we know? What happens to these children when they have this?
What usually, this is basically gene. So when a patient inherit this gene, they might inherit there are two genes basically. One we carry from our parents, one from mother and one from father. So if a patient carry these genes, only one gene from one of the parent and other gene is normal, so that is called trait. So obviously patient will not have any symptoms, but even if then some patients, if they have this kind of thing, they also complain of problems. So basically they initially what happened, because of the hemolysis they will have low hemoglobin, or they will feel fatigue. At the same time, these sickle red blood cells, they causes the vascular problem, endothelial damage, and these polymerizes, these RBC polymerizes and block the vessels. So that lead to loss of supply of oxygen to this tissue, and that possibly cause the pain. So it depends which site it mostly involved, and the symptoms varies in each and every one.
So is it quite possible, like ma'am said, that it is once symptoms happen? So most of the patients, most of children do have anemia in India. So is it that we don't do peripheral smears and we don't get to know about it, and we presume that these are iron deficiencies? I mean, it's just a query. Is it so?
No, it's not.
Can it be picked up in absence of a peripheral smear?
Yeah.
See, the thing is, it can manifest at birth also. This is one genetic disorder which can manifest also at birth. I mean, a very common symptom in children is pain and swelling of the fingers, called dactylitis, and it is a manifestation of severe disease. Otherwise, a child might not manifest at all until adulthood, and what happens is, these are silent occlusion of blood vessels that goes on, and maybe at the age of 20, 22, you come to know that, okay, this is the problem. How do you know? There is a heart problem or there is a kidney problem, and you realize it was all happening for last 20 years because of sickle. So it should be a part of the screening program, because saying that, I mean, a large part of Maharashtra is also affected. I mean, Nagpur, Maharashtra, I mean, Nagpur in particular, I mean, across, the straight of the society, there is affection. Same for Andhra Pradesh, same for Orissa, same for certain parts of Bengal. So the affection is there. I mean, as you said, that we have not picked it up as we should, because awareness is lacking. We do thalassemia screening, but we don't target sickle.
Agreed. So ma'am, how do we diagnose sickle cell? If we are suspecting, what all tests would you conduct to know whether it is sickle cell anemia?
Yeah, diagnosis, there is very cheap and very easy tests are available, like simple blood count. When we do the peripheral examination of the blood cell will indicate, yes, this might be sickle shaped cell. So what we do, sickling test, very common and very cheap tests, and to confirm the diagnosis we have to do hemoglobin electrophoresis. So hemoglobin electrophoresis will indicate, yes, the sickle hemoglobin is present. The advantage of doing this test is very simple, that you can diagnose that it is sickle cell hemoglobin. Apart from sickle cell hemoglobin, other hemoglobins, what all are present. Sometimes, because it happens that patients have both sickle and the beta thalassemia. So patient present with beta thalassemia intermediate and with the problem. So hemoglobin electrophoresis is the very diagnostic test.
So once we've established that somebody has sickle cell anemia, so what would be the treatment for these patients?
I mean, once you establish a patient has sickle cell anemia, there are two aspects, as Dr. Sarita mentioned, that there is either increased destruction of blood hemolysis, or their crisis, means patient complains of repeated painful episodes. Now, once these things are established, or even if they are not established, one has to monitor the organ function periodically, because there is silent organ damage over a period of time. The second most important thing is that because of this vascular occlusion, silently we lose the spleen. It's called splenic infarcts, which happen repeatedly, and by the age of 5 years most patients are hyposplenic, means there is no splenic function, and they are very prone to infection, and a simple penicillin can prevent this, because in Africa or even in US, before it was realized, majority of children died because of capsulated organism induced pneumonia or meningitis before the age of 10 years. So a simple measure can prevent infection related deaths. Now, coming to what you do for the painful crisis. Painful crisis can happen either because someone is dehydrated or someone is lacking oxygen in tissues for other reason. This is exacerbated by this. Extremes of temperature. So those are the things to be avoided. I mean, the children should be advised, the parents should be advised to avoid these extremes of circumstances, keep the child well hydrated, and if and when it happens, one has to rest, give painkillers, give lots of fluids. If that does not settle, the next thing one has to do or one can do is give blood transfusion. Now, if it is a hemolytic variant, that the hemoglobin is low, you can simply give blood transfusion and revert the condition for the time being. But if it's not so much a hemolytic as in an occlusive condition and your hemoglobin is on the higher side, just giving a transfusion will increase the viscosity of blood and it will cause worsening of the crisis. So what we do in that situation is do a red cell exchange, means take out some blood from the patient and give a normal healthy blood from outside. The other major problem that sickle cell anemia patients face is a stroke, which might often be silent because of occlusion of blood vessels for the same reason. So if our child presents with stroke, it is imperative that we transfuse, we try to reverse it as much as possible, and they are the ones who go on a regular transfusion or an exchange transfusion program. I mean, it doesn't happen in India, there is no such policy protocol in India, but that's how it's managed in the West. I mean, at least in the developed countries. The other aspect is that what you do in terms of other forms of crisis. Say, for example, you can have an acute chest syndrome, as it's called. The occlusion might cause severe chest pain and you have a pneumonia-like picture, and often there is an additional infection. So whenever a sickle cell anemia patient presents with a crisis and fever, we have to treat with antibiotics, we have to do the usual supportive means, and we have to do the other things. Now, there is another drug which is called hydroxyurea. It's an anti-cancer drug traditionally, and it was found to increase the level of hemoglobin F. Now, what is hemoglobin F? Sickle is hemoglobin S. Hemoglobin F is a fetal hemoglobin. Now, the nature has designed us in such a way that inside the mother's womb, the child requires to conserve oxygen. It is not doing a lot of exercise, it needs to conserve oxygen. So the hemoglobin F tightly binds to oxygen, does not leave it easily. So once the child is born, hemoglobin F gradually reduces and it's taken over by normal hemoglobin, which dissociates oxygen much more easily. Now in sickle, we need a bit of oxygenation of the red cells so that they don't become sickle. So the more the amount of hemoglobin F, the better it is for the person or the child or the patient. In that situation, hydroxyurea has been found to increase the level of hemoglobin F by inducing certain stress in the bone marrow, etc. It does work in some patients, it does not work in all. My major concern with that is, it is an anti-cancer drug.
Absolutely.
Although the claim
it has its own
safe.
demerits also.
It's safe, but that is the only medicine that's globally available for preventing crisis in patients with sickle cell anemia.
So, sir has elaborated beautifully that how we can manage the crisis phases, or avoid some end organ damages because of this. But is there something which is curative? Like here we are talking of more of preventive aspect or the symptomatic relief aspect of it. Can we actually cure it?
Yeah, so basically the sickle cell anemia, these are treated by what is your intent of treatments. So yes, supportive, as Dr. Chakrabarty has told, and the curative option is only one, that is an allogenic bone marrow transplantation. So allogenic bone marrow transplantation, what it is? So allogenic bone marrow transplantation is just a cellular procedure. It is different from the solid organ transplantation. It is very difficult even for doctors who are not involved in this field to conceive this concept. So what happens? The bone marrow is defective, or rather stem cell of the patient is defective. So we have to replace this defective stem cell and immune cells of the patient with the donor stem cells. So that this when the donor stem cells will go, it will form new healthy cells with new immune cells. So for that purpose we need basically an healthy donor. So the procedure, if you talk about the procedure, what it is, so our bodies are like taught that whenever a foreign substance go in, or anything foreign which comes under contact with this, it try to reject this. So that is why for bone marrow transplantation we have to first prepare this bone marrow. So what do? We condition bone marrow, means we make it empty so that it takes the healthy stem cells of the donor. So once the healthy stem cells are given and you have made this bone marrow empty, so for the couple of weeks there is no red blood cell, no WBC, no platelet, and almost empty, and this situation is completely incompatible with life, but we have to make them compatible. So what do we do with them? So we have to, that is why we have to keep in a room, in a special unit where everything should be sterile. So what we acquire the infection from these three sources like air, surface, water, and the food. So everything has to be perfectly sterile. We have to make them sterile, and it takes about 2 to 3 weeks for these stem cells to first they settle and they try to reside in the bone marrow. Gradually they proliferate their own population, then differentiate and then mature, and then they come to the blood circulation, and that time we see the mature neutrophil and platelets in the blood circulation, and that is, in the medical term we call it engraftment, neutrophil engraftment and the platelet engraftment, and that is the first success of bone marrow transplantation. So it takes too much time, so your patient has to be there for 3 to 4 weeks inside a sterile unit with everything should be sterile, like nurses who go inside the unit, they have to be sterile, the doctors, they have to be sterile, and the cleaning is very separate of that room. Whatever foods are provided to them, they all are properly cooked and microwaved. Even water is also properly, they have taken RO water, so we have to give. So this is the way we keep them for the 3 to 4 weeks perfectly all right. At the same time they have to be given blood and the platelet from outside till they have their own blood cells. So this is the nutshell, this is the normal procedure.
So I think it is really intense. Practically your patient is in an air bubble like a newborn.
Absolutely.
So you have to tide over those phases when patient doesn't have his own cells to fight any disease. But sir, are all patients that lucky to have donors? We really don't have these repositories also in India where you have donor cells. So how do we cater to these patients who really don't have people to donate?
See, that's one major difference between a solid organ transplant and a bone marrow transplant. A solid organ transplant comes under the Organ Transplantation Act because with a very minimal requirement one can be a donor. You don't need to be related, for example. That's why the laws are so stringent. But bone marrow transplantation is dictated by matching of cell signature, which we call HLA, or human leukocyte antigen. It's like a signature in each individual. And whether the body will accept or not accept those cells will depend on a bit of teller-like situation in the bank. If the signature matches, your check is cashed. If not, rejected. So chance of getting that sort of a match is only about 1 in 5 in a family with 5 brothers or sisters. So imagine in a nuclear family nowadays with maybe a couple of children, the chances are very, very low of finding a match within the family. And this has been a problem in the West for a long time. So what they did was they created what we call an unrelated donor registry, a volunteer unrelated donor registry. Now HLA is a very, very polymorphic gene. Means there are some 30,000 odd variations. So a chance of a random person to be matched with another random person is less than 1 in a million. Now Caucasians are lucky because their gene pool is conserved. They have evolved later in the course of evolution. As I told you, the primary human being was an African man or a woman, and gradually when they migrated, the Caucasian population developed, who lost their pigment. So white is not a thing of supremacy, it's actually losing
lack of something.
Which they don't realize, unfortunately. And a very interesting anecdote I'll tell you over here. When the white people migrated to Australia or New Zealand, for example, and took off the aborigines, or as they call it, the original population of those islands, they faced something which they never thought about, which is a fatal form of skin cancer called melanoma.
Absolutely.
Which remained the major cause of death in Australia and New Zealand in the white people, whereas the colored people are saved from, to a large extent, from those things. But that's an anecdote. So saying that, the Caucasians were lucky. In a repository of 100,000 people, the chance of a Caucasian getting the match is nearly 60, 70, 80%.
Which is very high.
Very high. Whereas in an Indian population, which is very hybrid in terms of a genetic composition, the chance of that in a similar repository is not more than 20%, I would say. And the chance of an Indian getting match in a Caucasian registry is less than 10%. So that thing largely puts Indians out of the equation for matched donor transplantation.
So how do you address this huge problem? It is...
Yes, we started addressing this problem nearly 10 years back when we addressed the very core of tolerance in nature. Our body is never tolerant to something foreign, but when a mother bears a child, the child bears half of the HLA or the gene pool of the father, but the mother tolerates it. That's why it goes through the entire duration of pregnancy. So this is basically the child is half matched with the mother and vice versa. And this half HLA matched tolerance is the root or the sort of basis of doing HLA half matched family donor transplantation or haploidentical transplantation. Apart from the Italian groups who started it in the 90s, and later on an American group started it in the 2000 and late 2000, we in India pioneered this concept of haploidentical transplant in 2010, and it's been nearly 10 years we are doing it, and we are really picked up in the last 5-6 years. So we have addressed this problem largely because for every child there is a parent to be a donor half matched. For every parent there is a child to be a donor who is a half matched, and by and large at least 80% of the siblings are half matched with the index case. So in that situation almost 95-96% of the population will have a half matched donor.
So at least that opens up the door for cure for them. And I believe after your pioneering efforts, I see a lot of people following your footsteps. We are getting to hear more people trying to. Initially, I think people were very, very fearful and reluctant, but a lot of people are following your footsteps. So what is the access to the BMT, the patients of these sickle cell disease?
So
There is no access. Let's be very clear. In India, I'm talking about there is no access. Africa, and what we have seen, there are a lot of centers in India who do sickle cell transplants in African population as a part of medical tourism, or the Arabic population as a part of medical tourism. But I can vouch that none of them have transplanted a single tribal Indian for sickle cell disease. That's the pathos of the situation in our country. That we have traditionally, as a society, we have ignored, like the white European or the American or the British society have ignored the black population who they brought as slaves to their own country. Similarly, we as a country, we have ignored our original or the tribal population, and there is absolutely, in fact, we have no data as to say what is the clinical outcome of these, say, 1 lakh people suffering from sickle cell disease in our country. Forget about transplant. So it's a very pathetic state of affairs. There is no access, and this is something I've been lobbying for some time to say that there should be access for children with sickle cell disease for better treatment, including transplantation. And if it happens any day, it need not be that we will do it, anyone can do it, but it should happen.
Absolutely.
So there is complete lack of access.
There is a disease which is curable, and it is just the access which is denying cure, which is really, really deplorable.
It is very important very, very important that say sickle cell transplants were done in very severely affected patients only. It started in US, where very severely affected patients were initially chosen. So 50 patients done over 5 years. The results in 1995 were on 50 patients, or 80 to 85% survival on very, very sick patients. Now when we learned more about how to do these transplants and what are the problems, by 2000 this improved to 85 to 90%, and a survey of 1,000 sickle cell transplants done across the world in 2017 showed that the overall disease-free survival is 92%, which is, incomparable. No other disease in the world has such good results, but no other disease has been so ignored in terms of offering a curative option.
So anything new coming up in terms of medications also? Are we, looking at a brighter future in terms of pharmacy, some pharmacological?
In the recent few years, few of the drugs have been approved by FDA, but unfortunately they are not available in India.
At my age, I only talk of the socio-political issues in disease. So I will give you an example over here. For every 10,000 molecules approved by FDA for cancer, there is less than 1 molecule which has been researched for sickle cell anemia. I'm not talking approved, less than 1 molecule researched. Now in the last decade, because of intense lobbying, as you know, the Black Lives Matters sort of lobbies have come up. So there has been an intense pressure to do something for sickle cell disease, and a few of these molecules have now come up and achieved FDA approval, but saying that they're expensive.
Of course. Yes, the access, just like BMT, I think this would be again a factor that they would not reach.
It is not
available in India.
Access is not there in either India or Africa, where the majority of the population lies. So it is more a theoretical proposition that there is a molecule, but who uses it, where they use it.
Apart from these drugs, the gene therapy, we are also listening about the gene therapy, but which is also not available in India, although few trials are going on abroad, but it's not available. So these all things are beyond the reach of Indians.
So in a nutshell, I can say that we as of now, the only curative options, at least for Indians, we would say would be a BMT, and if there is no donor, then a haplo BMT is a safe option. Yeah. So any message, sir, you would want to give to the audience with this regard?
Firstly, haploidentical BMT for sickle cell disease or thalassemia should not be done casually by anyone, anywhere. I mean, it took us literally, I mean, first 5 years we did something like 3 or 4 transplants in thalassemia and sickle cell anemia. The first 2 transplants in thalassemia, although they succeeded initially, the patients had mortality from other reasons, complications. The complications which have never been described in the West, either in the context of haploidentical or other forms of transplantation. So whenever we adopt a treatment style or treatment modality which has been successfully done in the West, we just take it for granted that it will work in our population. It doesn't happen that way. We are very different people. So in the last 5 years, we have developed a protocol which gives us nearly 90% success in both sickle and thalassemia. So as I said, that this has taken time to develop, and you just cannot go and do a transplant, a half-matched haploidentical transplant in either of these diseases very casually. So it has to be better done within the framework of a clinical trial with a full understanding of the pros and cons, etc. But I would, sorry, you were saying something?
Yeah, so at the same time, I will say that we just do not select any donor who
Randomly.
is just a half match. We have a particular criteria and we have protocol, because apart from HLA, we looked into the detailed study of each and every cells which are found in the donor, and we have certain criteria. Yes, these cells, presence of these cells are going to make harm in the patient, and or these cells are beneficial. So depending on those cells study, we try to choose a donor. So it's not just anyone who has parent or anyone like sibling half donor or children half donor, anyone can come and donate. Like
So a standardized,
Yes.
Standardized procedure with a stringent criteria of selection. That is
Yes.
what is being followed
Disease
here.
specific.
and
Disease
disease
specific.
specific.
So we choose separate type of donors for malignant diseases versus non-malignant. And I just hope, I mean, when we talk of a message, I just hope that the most deprived population of our country who are suffering from an enormous burden of this disease, get access to treatment through a government policy and protocol and awareness. Otherwise, they will keep on suffering silently without any one of us knowing.
So I think a public health program to first screen them, and then once they are screened, and then they are made to have an access to the treating doctors wherever
Yeah, access is
possible.
not difficult because these areas are largely governed by the mining companies, whether it's PSUs or they're private. It's a social responsibility for them to provide this to the people of that area.
So I think this is for the lawmakers and to the NGOs to look into it, but I think the message from here is that one should be aware there is a disease called sickle cell anemia. We beautifully described what the symptoms can be, how we diagnose it, and there is an available cure. So anybody who is affected by it should access a hemato-oncologist with an experience of such type of transplant, so that at least they can deserve or get that chance of being cured. Thank you so much.
Thank you.
Thank you, Kanika.